A total hip arthroplasty requires aggressive preparation of the acetabulum. The native cartilage and subchondral bone are reamed away to create a bleeding hemispherical bed. Once the socket is prepped, a titanium prosthetic cup is impacted into the bone, and metallic screws are driven through the shell to lock it into place. This hardware must immediately endure immense mechanical stress. The moment a patient stands, the joint absorbs loads exceeding 3 times their body weight, requiring absolute primary fixation. Securing these screws is a matter of straightforward mechanics. The difficulty lies in driving them blindly into the pelvis without piercing the hazards resting just millimeters behind the bone wall. Viewed from the joint space, the human pelvis appears to be a massive solid block of dense bone. But the deepest aspect of the acetabulum is a thin osseous wall, separating the joint from the internal pelvic basin. A concentrated network of major arteries, veins, and nerves press directly against the inside of this thin cortical boundary. These structures are invisible during the procedure. To safely place hardware, the surgeon must utilize a geometric matrix that maps the hidden anatomy through the bone. This map begins with a fixed, palpable anatomical landmark, the anterior superior iliac spine, the ASIS. Drawing a line from the ASIS through the center of the acetabular socket establishes the first axis. A second line perpendicularly bisects it at the center. This creates 4 zones: the posterior superior, posterior inferior, anterior inferior, and anterior superior quadrants. These lines are not arbitrary markers. They directly correspond to the layout of the intrapelvic anatomy. Mastery of this 2-line matrix is required to place hardware without causing iatrogenic injury. In the anterior superior quadrant, hardware placement is precluded. Directly behind this quadrant lie the external iliac artery and vein, which carry a massive volume of blood under high pressure into the lower extremity. A surgical screw penetrating this zone will pierce the external iliac system, resulting in immediate and potentially fatal hemorrhage. The anterior inferior quadrant presents very similar hazards. The primary threats behind this zone are the obturator vessels and nerve, which run along the inner pelvic brim. This area houses a vascular bridge connecting the inferior epigastric branch to the obturator vessels, the corona mortis, or crown of death. This arterial connection is tethered across the bone, making it susceptible to avulsion from stray hardware. Even routine retractor placement can sever the corona mortis. If the vessel retracts deep into the pelvis, the resulting hemorrhage is difficult to control. The entire anterior hemisphere is a vascular risk zone, where hardware placement is an unacceptable gamble. This forces surgeons to utilize the posterior half of the acetabulum, beginning with the posterior inferior quadrant. This zone contains the inferior gluteal nerve and internal pudendal vessels, which exit the pelvis and re-enter through the lesser sciatic notch. Because of these structures, the posterior inferior quadrant is a conditionally safe zone, used only when the mechanical stability of the cup requires extra fixation. That leaves the posterior superior quadrant as the primary target for all acetabular screw placement. There is an apparent contradiction here. This quadrant sits anterior to the superior gluteal vessels and the sciatic nerve, the largest nerve bundle in the body. However, the bone architecture here is unique. The pelvis directs upper body weight through this quadrant, requiring thicker bone and cartilage. This extra density allows screws to achieve deep purchase entirely within the bone, avoiding the inner wall. The trajectory angle in this quadrant also directs hardware away from the intrapelvic structures. Bone density and hardware trajectory work together to transform this neurologically crowded quadrant into the surgeon's only reliable safe harbor. Hardware precision is equally critical when shifting focus from the pelvic socket to the proximal femur. Unlike the pelvis, the adult femoral head relies almost entirely on a single blood source to remain viable. That lifeline is the medial femoral circumflex artery. It wraps around the posterior neck of the femur, sending tiny posterior-superior retinacular branches into the bone to feed the femoral head. This anatomy creates a hazard during trauma surgery, specifically when using a piriformis start nail to treat femoral shaft fractures. Driving an intramedullary nail downward through the piriformis fossa physically crushes these delicate retinacular vessels directly against the hard cortical bone. Severing this supply causes avascular necrosis, the death of the bone cells within the femoral head. One wrong entry point condemns the entire joint to necrosis. In the operating room, where tissues are retracted and the field is obscured by blood, rote memorization of anatomy often fails. A surgeon's physical orientation to the joint changes depending on the approach, whether they are viewing the hip from the front, side, or back. Regardless of the angle of entry, the internal mathematical matrix of the acetabulum remains static. Relying on these geometric principles allows a surgeon to navigate around invisible hazards safely. The geometric matrix provides a persistent mental map of the hidden vessels and nerves, offering a constant reference regardless of the surgical tunnel being used. When the surgeon internalizes these quadrant boundaries, the invisible neurovascular threats are no longer abstract risks, but fixed spatial constraints that define every millimeter of hardware placement.